Thank you very much, Dr. Lee, and thank you for inviting me to take part in this very important forum. I'm going to be talking about why do we need to prevent the harmful use of alcohol, and I'm going to first show you a couple of slides showing the prevalence of alcohol consumption worldwide. More generally, I should say that I have quite a large number of slides, all of which will be available to you following this forum. Some of the slides I'm going to concentrate on in some detail. Some are purely illustrations, which I will show you just for a few seconds. Worldwide, there are 2 billion adults who drink alcohol. And most people drink alcohol without experiencing any harmful consequences. But in every society, there is a proportion of people who will experience very significant alcohol-related harm. Alcohol consumption in society is not a fixed entity. This diagram here, this map, shows the amount of alcohol consumed per head of population in various countries worldwide. And you can see that there are some countries where alcohol consumption is extremely high and alcohol problems are correspondingly high. You will see other countries where the reverse is the case. Alcohol consumption is low and alcohol-related problems are rare. It is important to realize that things can change rapidly in any country, in any society. Alcohol consumption was relatively uncommon in many countries in Asia 50 to 70 years ago. However, over the last 20 to 30 years, alcohol-related problems and harm have increased, as has alcohol consumption in many countries in this area of the world. There is a spectrum of use and misuse of alcohol. As I said, most people drink alcohol without experiencing any harmful consequences. There are people, though, who have developed a repetitive pattern of alcohol consumption, which puts them at risk of diseases, of psychological problems, of personal or social problems. There are people who are in the category that we call harmful use of alcohol, who have a repetitive pattern of alcohol consumption and are experiencing harm. And then at the top of this pyramid, there are a group of people who have the alcohol dependence syndrome. This is addiction to alcohol. It means that their brains have changed in a fundamental way. They are not able to control their alcohol consumption. Instead, alcohol increasingly controls them. I'll draw your attention to the lower part of this slide. It shows what are the current ICD-10 diagnostic guidelines for alcohol dependence. Alcohol dependence essentially is an internal driving force which drives that person to drink alcohol and to continue to drink alcohol, often without thought. The brain changes are to a large measure in the subconscious areas of our brain. So it is not a repeated conscious desire to consume alcohol that is the problem. It is the fact that brain changes occur, which mean that there is a subconscious driving force which drives that person's use of alcohol ever onwards. The diagnostic guidelines include a strong urge to drink alcohol, sometimes called craving. Impaired control over its use. Impaired control over the amount that a person uses. My patients describe that they try to limit their consumption to 2 or 3 drinks, but they end up in a single drinking session drinking 2 or 3 bottles of alcohol. Importantly, as the dependence syndrome develops, there is a higher priority given to alcohol consumption over other normal, regular human activities. There is an increase in tolerance, often a withdrawal state, and then continued use of alcohol despite the harm that it causes. So that is the addiction. An important implication of the alcohol dependence or addiction is illustrated in this graph here. Most of the substances take a considerable amount of time for the addiction to develop. Alcohol, for example, can take 5, 10, or 15 or more years for the dependence to develop. This diagram shows on the right side that if a person who has developed an alcohol dependence then, after a period of non-use of alcohol, resumes use of alcohol, there is a rapid reinstatement of their alcohol dependence. The addiction, in a phrase, is reactivated, and whereas it might have taken several years for the person to develop alcohol dependence in the first place, when they resume drinking, the escalation back to the previous level of drinking occurs within a few days. That is a very powerful disorder. That is what we mean by addiction. There are numerous complications from alcohol, harmful drinking, and alcohol dependence. These are some of the physical complications. Alcohol is a small compound which gets into every part of the body. It has innate tissue toxicity, and so can cause diseases in all the major body organs and body systems. It can also predispose people to become malnourished, to become susceptible to infections. There are many diseases which are directly related to alcohol toxicity. This next slide is an illustration of one of these. This is a patient of mine from a number of years ago. He gave his permission for his photograph to be shown at conferences and forums like this. He did not want other people to go down the pathway and experience what he had experienced. This is a 32-year-old man. He has the features of severe liver disease. You may notice that he has a yellow discoloration of his skin. He's jaundiced. He has yellow discoloration of his eyes. He looks unwell. He's not focused. He has skin changes, which some of those of you with an internal medicine background will recognize as indicative of serious chronic liver disease. This man had alcohol-induced hepatitis and cirrhosis. 4 days after this photograph was taken, he became unconscious. 10 days later, he was dead at the age of 32, leaving behind a wife and 2 young boys who were just bereft. They had no idea of how his drinking had developed. They had no idea how serious his health had been affected. So that is why we have preventative measures, early intervention approaches, treatment. Beyond the physical, there are many, many neuropsychiatric complications, including severe, permanent brain damage. There are numerous social complications affecting a person's personal relationships, their finances, their employability. They often develop problems with the law. They have arrested for various offences. So very clearly it is necessary for any organised society to have a spectrum of responses to prevent alcohol-related harm. The responses broadly can be categorised into four. Primary prevention approaches to try to help people reduce their consumption of alcohol across the board. Secondary intervention approaches, screening and brief intervention for people who have risky or hazardous patterns of alcohol consumption. Tertiary intervention, which includes the treatment, an accessible treatment of people who have an established alcohol dependence or established alcohol-related diseases. This slide shows some of the evidence-based primary prevention approaches, some of which I know are employed in Korea. They include regulating the physical availability of alcohol. They include the use of taxation and pricing. They include determining what would be a legal level of legal age to drink. Countering drink driving. One of the great successes in Australia has been the systematic approach to the prevention of drink driving. I have personally been stopped by the police while driving my car 26 times in Australia in 30 years. It is a systematic approach. Everybody expects this. You are not surprised if the police stop you. I should say, every time my alcohol concentration has been 0. There are other approaches such as warning labels, provision of information, and regulating promotion for alcoholic drinks. Brief intervention is based on identifying people who have hazardous alcohol consumption. There are many, many trials, and overall there is compelling evidence for the effectiveness of brief intervention. Here is an example from an early study that we did with the World Health Organization, and you can see in the last column on the right the reductions in alcohol consumption per week which occurred in people who had 4 to 5 minutes of simple advice, a 27.5% reduction, advice and counselling lasting for 20 minutes, 29% reduction, and extended counselling which lasted for 40 minutes, a 38% reduction, with corresponding reductions in frequency of intoxication and alcohol-related problems. So brief interventions, even as short as 4 or 5 minutes, can produce very significant long-term, short-term, medium-term, and indeed long-term benefits. There are many systematic reviews of brief intervention. This is an example of one that we published in 2009 and which we are updating at the moment. And this shows some of the wealth of data attesting to the benefits of brief intervention in reducing hazardous consumption. I've got a few slides now which show you how you might develop materials to offer screening and brief intervention in medical practice, in healthcare systems, in clinics. In our part of the world, we use a program called the Drink Less program. This is the audit questionnaire, which is handed to patients attending general practice by a receptionist. The person then has their audit score fed back to them, and depending on their score, they're put provisionally into a non-hazardous group, hazardous drinking group, and an alcohol-dependent group. These are some of the materials that we have, and you can see they're designed to be fairly attractive. A development in recent years has been the use of electronic screening approaches using the internet or intranet, and the delivery of tailored brief intervention advice. This table shows that there is an equivalent effect of electronic brief intervention in a group of young people aged between 18 and 25 compared with established brief intervention approaches. Finally, I want to say that for people with alcohol dependence, we have a range of evidence-based treatments available. This shows the 10 key components of treatment for alcohol dependence. And you will see that they combine information provided to the patient. They include the patient taking on a certain level of personal responsibility to change themselves. It includes detoxification, medications, the identification of underlying comorbid psychiatric disorders, the involvement of family, the involvement of the person with an appropriate 12-step fellowship, at least in our part of the world, aftercare programs, and then the person thinking how they can change certain aspects of their life so that they do not put themselves at high risk of relapse. I have a number of slides which show some of the detail here, including detoxification, pharmacotherapies for alcohol dependence, the systematic reviews of the three principal medications, naltrexone, acamprosate, and antabuse. And I would finally like to say, first of all, alcohol and hazardous and harmful alcohol consumption and alcohol dependence are a major cause of illness and loss to individuals, families, and the community at large. There are established prevention, brief intervention, and treatment approaches appropriate to different sectors of the community. Often these interventions, these approaches, are not initiated or they are not known. With involvement of the whole community, which I hope is what would happen in Korea, there is considerable scope for minimizing alcohol-related harm. Thank you very much.